right away. Dr. Hardy is here with us. Thank you. Dr. Aaron Burnett should be here as well. But this is way out in the suburbs for him, so we'll give him some time. Please sign in. Do you have a pen? It's my favorite pen. I'll take it back, please. All right. We've got some kind of cool stuff to go over today. You guys are going to get a new medication. You're going to get a replacement medication if you haven't already. We're going to go over a call. Talk about some guideline changes that are coming out here very soon. So we've got a lot of stuff to talk about. Since we're waiting for Aaron, let's talk about a little bit about some of the guideline changes that you're going to see in May. So as we do, there will be an update to the app here in May. And some of the things that you're going to see on it are nothing groundbreaking necessarily. Well, maybe one thing's a little bit groundbreaking with the addition of whole blood administration. So Lakeview right now, good morning, Aaron. Good morning. Just way out in the suburbs for you. Just kidding. So Lakeview started carrying whole blood as of yesterday. The indications for that are traumatic hemorrhage, traumatic shock. So that's what they'll be using that for. I can see someday, possibly down the road, that you guys might be carrying something similar, whether that's whole blood or packed red blood cells. But Lakeview's going to try it out for us. I suspect it'll go very well for them. And then as services see the need, you guys can maybe pick that up as well. Some of the other things that are coming out in this new update are some documentation standards. The expectation that when you have abnormal vital signs that they are addressed in the narrative, not just in the line of vital signs there. So if you have somebody who's tachycardic in the 130s, that you've addressed that and essentially especially for those non-transports, but you have noticed those vitals, you've addressed the vitals, and if it is a non-transport, that you brought it up with that patient. So not saying that somebody with abnormal vital signs can't be non-transported. They certainly can. That's up to them most times, right? But just a note in your narrative that you address that with them. Also, repeat vitals. So we've added back into the guidelines that vital signs on critical patients should be obtained every 5 minutes, and that for non-critical folks every 15. And then a lot of folks' documentation software already has this in there, but with your initial assessment, putting in there a GCS and or an AVPU score. Some of the miscellaneous updates, as I've said before, we're trying to take out the reference to stab room, and instead of requesting a stab room, we ask that you use the term red medical or red trauma. So if you're requesting a red patient, it shouldn't just be red. You should say red medical or red trauma. Does that make sense?
Can I just clarify that versus TTA?
Yes, absolutely. So a green patient is someone that can go out to triage. That person can walk, wheel, get themselves to the bathroom, can sit up, can take care of themselves. A yellow patient can't do those things, but they don't need to see a doc right away, so they need a room. Red patients are someone who you want to have them see a doc right away. If it's a medical patient, let's say you have an abnormal EKG, but it doesn't quite fit a STEMI, but you think there's something there that a doc needs to see, that would be like a red medical. A red trauma could be like a open tib fib, but that's an isolated injury. They don't need the TTA team, but they certainly need to see a doc right away. And then of course we have our code stroke still, we have our cath lab activations, we have our TTA. So red is not a replacement for TTA. It's just a lower acuity. Feel free to ask questions at any time.
Just out of curiosity, is there any thought or discussion of doing something like HCMC does with like the dock at the door where it's could be a yellow, could be a red, or
We don't really support dock at the door, so you should be able to get a dock pretty darn quick with the red. You're just not going to get it at the door. So putting the trust on you guys to make that decision. So yeah, we hear some of the West Metro services ask for a dock at the door, and I've heard MRCC say, you know, we'll get you a dock in the room just as soon as possible.
This is across the metro, so that's supposed to be going away too.
Okay.
So red medical, red trauma for both sides, so that, we're trying to increase the interoperability of the two MRCCs really, so to really have them function identically as much as we can, so we're getting rid of stage room, dock at the door is supposed to be going away, it's supposed to just be, the red identifies you need a dock at the door, in the room.
okay.
These things seem to take a long time for everyone to get on board between medics and the MRCC operators. I still hear MRCC say stabrum, so it takes a little while. But you guys know the right thing to do. Guidelines, we have added ultrasound to the Assistly PEA guideline. You guys are pretty good about that, I'm pretty sure. I did open up the Butterfly app today, and I think maybe it's just not updated because I haven't seen a scan saved in a while. Did you save your scan from last Saturday?
Recorded part of it.
Okay, maybe it's still in there as a signed draft?
Yeah.
Okay, we'll follow up on that and make sure that those are getting up, because I didn't see them this morning. I wanted to include that. So ultrasound is, if you have it, it's expected that you use it for those PEA asystoles looking for cardiac function. Pain control. This is for you guys. We're going to go over IV acetaminophen today. Some of this other stuff was a little inconsequential. Yeah, I don't know. So once this comes out, so please in the next week or two, open up your Regions app. It should prompt the update. And then if you go into the front matter section and then go down to what's new, this is what you'll see there. So it's right now it's in the QA version, so it's just essentially being proofread, but it's probably going to look exactly like this. So. All right, I trust that most of you guys have heard about, at least, IV acetaminophen, that you guys are going to be trialing this for the system. I kind of have high hopes for this. I hope that it works well for you guys. I trust that it will. The purpose of the IV acetaminophen is just to give more options for you guys for pain control. There's a significant population out there that either doesn't want opioids or shouldn't take opioids for any reason. A lot of times we don't treat our patients with pain control with those mild complaints of pain, but IV acetaminophen is really going to fill that void hopefully for us. So let's go through this right now. It's not a fast push, it's an infusion. It comes in a vial. Notice that it's a glass vial. So you will need different tubing, which you guys do have. It's vented tubing. It's the same stuff that you got. It just has on the drip chamber, it just has a little valve on it that you just pop off. So, because the glass vial won't collapse, it has the vented tubing. So make sure that when you spike this and you are filling your drip chamber, that you've got that pop-off valve. So acetaminophen hasn't been used pre-hospital because it was expensive. It was about $100 a dose. It has since gone generic, so you will see it referred to as Offermed, Tylenol, of course, paracetamol, those sorts of things. But this vial right here says acetaminophen right on it, none of those other names. But as you know how medications go, this might be in shortage at some point. You might see one of these other medications. So how does it work? They don't really know exactly how it works. There's some theories out there that it blocks certain enzymes in the brains that amplify pain signals, that sort of thing. For fever, it works on the brain's thermoregulatory center to lower the temperature. So not exactly sure of the science behind Tylenol, but as we all know, we've probably all taken it. It usually works pretty good for mild to moderate pain. The indications are mild to moderate pain. You could give the Tylenol by itself without giving any other opioids. But you can also use it in conjunction. If someone has severe pain, so 6, 7, 8 out of 10 type pain, you can give them maybe half a dose of fentanyl and then start the Tylenol. The purpose of that is to reduce how many opioids people are getting and then the side effects. There's a certain amount of patients that don't want opioids, like I said before, because maybe they're in recovery. But we still want to be able to treat those patients. If a patient is taking Suboxone, they certainly don't want opioids, so Tylenol would work for that. And then it does help reduce fever in critically ill patients. I don't know that you guys will be using it for that. That's sort of more of an interfacility type transfer, but it's certainly possible that you could go to, I don't know, any number of group homes or something like that where a patient is maybe septic and has a very high fever. So it is in the indications there. Contraindications. So if a patient has liver disease, you want to be careful giving them acetaminophen. It's metabolized in the liver and it's not going to work well if they're in liver disease, so make sure that you're checking for that. Acetaminophen use within the last 4 hours, you don't want to give them more. So the regimen for folks taking repeated acetaminophen is every 4 hours. So make sure that you're asking about other pain medications that patients are taking. I have a slide that goes a little bit more in depth what some of those medications might be. It's indicated for patients greater than 70 kilograms, which is about 150 pounds, which seems like a lot. I kind of had a discussion with some of the docs in the office yesterday about that 70-pound threshold. I don't know if you docs have any thoughts on that. I mean, if we have a 130-pound adult, can we give them Tylenol?
I mean, we're not going to weigh people, right? So, I mean, use your judgment and everything. The problem is it's a full gram, and we don't have pumps, right? So we can't titrate it really. So you're not going to like get someone in trouble, but if they're really tiny, like don't give them Tylenol. So
there is pediatric dosing for that, but because you don't have an infusion pump, we can't properly dose that. So we left out the pediatric dosing on this, just for simplicity.
You just want us to eyeball it and then.
yeah, you just ask them, hey, how much do I? Most people, you know.
Or I'm saying you can just eyeball the amount that we give, or do you just want us to go ahead and give the whole gram either way?
Yeah, just give the whole gram.
Okay.
Yeah. I mean, as long as you're 70 kilos, it's 10 to 15 milligrams per kilogram, so a gram is appropriate for anyone over 70. And again, we're trialing this right now, so if we really run into we had like 10 patients, we really wanted to give it to them, we couldn't, we'll troubleshoot and figure something out. That's why, so we're only doing this with you guys, so we're gonna work the kinks out and see if it's effective, see if it works, see if we're having issues like that, and if we are, we'll definitely address them. Like my gut tells me that's not gonna come up a lot, but I mean, we'll see.
And as always, of course, an allergy to acetaminophen is a contraindication. There's some precautions, some things to be aware of. They're not relative or they're not absolute contraindications, but somebody that is intoxicated or has a history of alcohol abuse probably has a pretty sick liver in the first place. We want to think about maybe not giving them Tylenol, so use your judgment on that. The literature that I've read classifies significant alcohol ingestion as 3 drinks. So being careful there. And then some things you could potentially see from administering someone Tylenol is that they could get some GI or some hepatotoxicity, that sort of thing. So I don't think that you will see these side effects because, of course, you infuse this in over 10 to 15 minutes. So most likely what's going to happen is you're going to start this while you're transporting and you will wheel them through the hospital still getting that infusion. So it won't be fully administered to a lot of the destinations you're taking to. until that patient is in their room. And that's just fine. That is not a problem at all. So how do we give it? If we have the indications present and we have somebody over 70 kilograms, we're going to give them 1,000 milligrams of it IV over 10 to 15 minutes as best you can. There is PO dosing in here because our special event team carries oral acetaminophen, so that's why you will see the PO dosing. So how do we do that? So we spike the vial, you pop the cap on it, you flush the line, and then you typically would piggyback it into an existing IV line. So you're going to have 2 IV lines, right? So if you remember from medic school, you get your line started, you've got a bag of saline hanging, and you'll put this in probably the closest port or one of the closer ports down to the IV hub, and then start eyeballing your drip rate. So the drip rate is just over a drip a second, so that it goes in within about 15 minutes. So a little bit of eyeballing there. So remember though, before you start this, let's not give people too much acetaminophen if they've already been taking it on their own. Some of those drugs would be pain meds, sleep aids, cold cough relievers, that sort of thing, and of course headache medications. These are just some of the medications you might see that don't necessarily have acetaminophen in the name, but if you're on the fence about whether you think they have it or not, ask to see the vial. Look at them and make sure that there's not any in there already. So
Ibuprofen, aspirin are fine, so it's just acetaminophen.
These are the guidelines that you will see. They're not in your app just yet, but they will be very soon. So right now it's just the adult pain management. Again, we said that for severe pain, you could use it in conjunction with your fentanyl. You guys don't have morphine, correct? Okay. So for the immediate pain relief, if they have severe pain, you want to give them something to make them more comfortable, right? So you'd give them 50, maybe 75 of fentanyl, and then you could start your acetaminophen down here. So the IV dosing is right here. Or, excuse me, it's not in there quite yet. Oh, it's over here. It isn't over here. So there you go. And then, of course, there's the acetaminophen medication guideline itself that'll give you all the contraindications. My PowerPoint is basically a breakdown of this guideline right here. So. All right. It's a fairly straightforward medication to give, so there's not a lot to it necessarily. As long as you know the indications, the contraindications, you should be good to give it. So just a quick scenario here. So you've got a 24-year-old female. She's seated at the park. She's alert. She's oriented. She looks pretty uncomfortable. She has left ankle pain after tripping and twisting while jogging about 30 minutes ago. She rates it 6 of 10. There's not an obvious deformity there, but there's some swelling and tenderness. She doesn't want to bear weight on that ankle. And she tells you that she's in recovery from opioid addiction. Vitals look good. So how are we going to treat her? Obviously, we're going to think about giving some aspirin here, but what are we going to do first? Anyone? What's that?
Ice.
Yeah.
Ice pack, sure, absolutely. So treating pain with ice is a good thing. What else can we do? So what do we usually do for like orthopedic pain? Splinting, absolutely. So splint it. What else?
Does she want to go to an ER and get herself to urgent care?
She says yes, she does, Greg. Please take me. So you assist her to the stretcher, right?
Yeah, that's what.
She wants some pain control. So then we can give her some acetaminophen during transport. And of course, that'll be something that we will let MRCC know that you guys are carrying, but don't be surprised if you get a operator say, what are you giving? Or for a lot of ERs are going to be surprised as well, especially outside of the health partner system. So there's your mild to moderate pain, right? So scenario number 2. So you got a motor vehicle crash. 45-year-old guy, he's in his driver's seat. He's alert, oriented, appearing in pain. His wrist doesn't look so great. It's got a bit of a deformity to it. He rates his pain 7 of 10. His vitals look good. Again, what are we going to do for this? Yep. So he's in severe pain. He's complaining a lot about it. So what do we think about some
First.
Yeah, absolutely. So we're going to take the edge off, right? You know, his sats are 94. We'd like him to be a little higher, so maybe not dosing him with a bunch of opioids and thinking about some acetaminophen. And then, of course, within our pain guidelines, especially for opioids, we're going to do all the monitoring that we can do for that patient. So capnography, making sure we keep an eye on SATs, EKG, that sort of thing.
So, one question we've gotten a couple times as we've sort of talked through this a little bit is, we used to have Toradol and we don't have that anymore. What about Toradol? And so Toradol is great medicine. The tricky thing is we don't have access to medical records and we don't have any blood testing capabilities. So what kind of got us jammed up in the past was people would have renal insufficiency, and that's one of the contraindications to Toradol, to any NSAID, ibuprofen. And so that's the reason that we don't have Toradol back on the trucks is, there needs to be a way that you guys can either look back and see like, oh, they had their kidneys checked in the last year, they were fine, so it's fine. Or be able to draw a little bit of blood and check if they have any influence. If we could do one of those two things, we put Toradol back on the trucks for sure. But without that, like I said, we had some patients that we got a little jammed up on because their kidneys weren't that hot and they got Toradol. So that's the beauty of Tylenol. It works with everything you have. If you have that patient who has, is on Suboxone, you can still give fentanyl to someone on Suboxone. It's just tricky. It doesn't work as well. The Suboxone is blocking the receptor. So if that's someone you're going to do low-dose ketamine, you can do low-dose ketamine and Tylenol. You can do anything and Tylenol. You can add Tylenol to anything we'll do at the hospital. And there's an opiate sparing effect. So even if the Tylenol doesn't get you this magic pain control right in front of your guys' eyes, the studies say it's going to decrease the amount of opiates those patients need in the next 24 hours. So it's got a longer term effect. And this ties in with sort of our awareness and in response to the opiate epidemic. We know, because we've heard from you guys, that there are patients that are in pain and you think it's legit pain, but when you only have one tool in your toolbox to use, then people get that tool. And so, we've heard the stories about people who tweak their back and they're really hurt, it's legit, but they probably don't need fentanyl. But if all you have is fentanyl, your options are either let them sit there and suffer or to give them fentanyl. So we're trying to make a middle ground there where you can still feel good. I'm going to give you pain control. And people, when you tell them it's going to be Tylenol, this is different than a Tylenol pill. This is a bigger dose, first off. If you take Tylenol over the counter, the dose is 650. This is a full gram. Second, it's going to come IV, so it's going to hit a little bit harder. And then third, we all know that when you get a medicine through the IV, there's an added placebo effect to everything, real or not. And so patients do feel better. And frankly, this was Dr. Hardy's kind of push for us because you guys use this a lot during residency in Wisconsin.
I use this all the time in the ER. It's great for your septic patients who you don't really want them taking anything enough anyways. Great for them. I mean, even if we're giving some kind of opioid, I try to do multimodal pain regimen kind of thing, so it's great for that. Your plasma levels are going to get faster when you give IV versus PL, so people are just happier. And then that way too, when you have these mild injuries, you have something you can do for them as well, if you're not giving fentanyl.
So I tell them, it's we can give you a pain pill. If we give you an oxycodone pill, that's going to help. But if I give you fentanyl through your IV, it's going to help a lot more. And so when you kind of explain to people like that, they seem to get it. And it really will, in your heart of hearts, work. I mean, the data says this helps. It might not take your pain from a 10 to a 2 if it's a fracture, but it'll take it from a 10 to a 7, and then they're going to only need half of the amount of opiates in the next 24 hours. So it's got that opiate sparing effect too.
So there's some research that's going to go along with this as well. We're only able to do that at Health Partners hospitals, but they will track how much opioids the hospitals are giving in these patients that have gotten acetaminophen. So again, looking to see that fentanyl administration and morphine administration goes down when we're given Tylenol. So
And we're gonna use our experience here to decide if we wanna roll it out wider. So to your point, like if you're seeing things that we probably need to tweak, like this is what we're doing. So if we're running into that weight-based barrier, or if you're like, you know, the IV stuff's great, but sometimes we do just wanna have a little PO. Sometimes just a pill will be fine too. Or, you know, if we start seeing a whole lot of kids that we really wanna give this to, maybe we consider doing some oral acetaminophen for kids, or figuring out how you can draw with a 60 cc syringe off the vial to get the right dose. You know, there's a million things we could do. This is all brand new, and there's only a couple people doing it in the country. It's pretty cutting edge. So we're gonna figure it out together, help us figure out how to make it better. And so let Matt know what you're running into, what ideas you got. Because again, we're trialing this at White Bear Lake, and then based on what we learn here, we'll decide if it's appropriate to roll out wider.
So we need your feedback on this. We want to see when you're using it, how you're using it, and how you think it could be used, for sure.
Because we really do want to make a move to multimodal pain therapy in the field, where we have more than just opiates. We'll always have opiates, because there's no substitute for opiates for fractures and things like that. But to be able to really be conscious about how we're treating pain and saying there's more than just the opioid receptor involved in pain. Let's hit some of those other receptors. And I would love, we keep watching to see if the point of care lab testing is coming down in cost. So if we could have a way to do lab testing in the field, like that is another thing we're very excited about, and it's just a financial barrier now. But you know, we have iStats in the hospital where with a drop of blood, you can get off a venipuncture, you can get a blood gas, you can get a hemoglobin, you can get a basic chemistry panel like a potassium, see if their potassium's high, you can get a creatinine, you can get a troponin, you can get a lactate. The problem is the monitors are still in the thousands, and not even that, they're just really finicky. Like at the Twin Cities Marathon, the iStat rep brings an iStat out because it's marketing, right? Everyone's like, oh, this is so cool. But they're so finicky, like if the humidity's not right or the temperature's not right, like half the time someone's having to wear it under their clothes, like against their body to keep it warming up, and then if it's a hot day, we're trying to like put it in the refrigerator for 4 minutes at a time and taking it out. So it's not just the cost, it's that the devices are not durable enough for the field use. But as they come down in price, as they get more useful, like I'd love to be, you know, teaching you guys how to interpret a blood gas and decide, well, are we going to do BiPAP if we're going to, or CPAP? If we're going to do CPAP, do we increase the oxygen concentration, or do they just need the pressure? Like that's all stuff we could start talking about if these devices come down in cost, then we can get blood work in the field, which would be super cool. So we're watching. You guys will be one of the first if we get it.
My question was, do we need to let Johns or United know anything specific if we're bringing these patients in on this, or is this more for we're going to regions only kind of deal?
You can transport to any hospital.
Okay.
They're going to have questions for you. Hopefully, you guys understand this. There shouldn't be much more you need to explain to them that you couldn't find the answer to in the guideline. So just reference your guideline.
And I mean, I think they're going to be super supportive. Like I think this is super cool. Everyone's trying to do more than just opioids. And so to that point, maybe if the bottle runs out before you get there, just leave it hanging so they can see it, you know, just leave the bottle up. But it's super appropriately marked and everything. The thing that gets the hospitals bent out of shape is if we like mix our own bags. So, you know, if we take some ketamine and put it in a liter of normal saline to infuse it slowly, that gets them worked up because there's like labeling requirements and everything. This is just a perfectly labeled bag, a glass vial that you spike and infuse. So just leave it hanging. If it does finish, there won't be any problem. That's kind of what we're doing with the blood products too, is, you know, if Lakeview's going to infuse blood and the blood's done, you just leave the bag hanging so that everyone knows they got blood. Same with TXA. If you guys give TXA, just leave the bag hanging. If it's a vial, just pass it along like you always do. You know, we gave this medicine and this medicine. I don't think you're going to get any pushback. If anything, I think they're going to be like, oh, why aren't more people doing this? At least that's what I hope.
Some of the doctors might be a little bit confused at first just because it used to be more expensive and pharmacists in the past hadn't let us use it IV
Right.
because it was more expensive, but now people should start using it more. So.
Yeah, this was restricted. We couldn't use it in the ER because it was too expensive. And like the purists, the pharmacists, you know, they'll sit down and they'll say, well, the data is that oral is just as effective as IV, and like, maybe, but I think, again, we all know that this is going to be more effective than the pill.
If you run into a roadblock with a hospital and you're not coming to any sort of agreement on this, as always, refer them to us. Aaron will be happy to talk to him.
I think this, I think they're gonna be like, why isn't everyone doing this?
When I started in 2000, the ambulance service I was at, we had laughing gas on the truck.
That's actually getting some more attention. Because it's not an opiate, right? So the whole idea of non-opiate
Yeah,
pain control.
had it here too? Yeah,
The which one?
yeah. Laughing gas.
Oh,
Yeah.
What I'm really saying I got my eye on is there's this thing going.
I was gonna ask, what about like methoxyfluorine or something?
That's what I was just gonna say,
What's the
methoxyfluorine, yeah, exactly. So methoxyfluorine, it's called a green stick, it's approved in Europe, it's not FDA approved in the US, that's why. But we got our eyes all over it.
Yep.
So it's basically an inhalational anesthetic in a very low dose, that comes in a stick, and so